Today's episode of CareTalk is sponsored by Provider Solutions and Development. We all know that it's very difficult to recruit physicians and advanced practice clinicians. Supply is tight and getting tighter, with 124,000 physician shortage expected by 2034. Thankfully, PS&D has reimagined recruitment in order to address these challenges head on. They offer commitment, not commissions, quality, and not quotas. It's no surprise that partner organizations around the country have partnered with PS&D to improve recruitment, retention, and workforce productivity. Check it out for yourself. info.psdconnect.org/CareTalk. Welcome to CareTalk, America's home for incisive debate about healthcare business and policy. I'm David Williams, president of Health Business Group.
And I'm John Driscoll, the CEO of CareCentrix. David, we have a very confusing Supreme Court ruling on the esoteric 340B pricing. What's that all about? I think it's well beyond your and my competence.
There's no doubt, John. You know, if it were just 340, I could probably handle it. But when you put the 340B on it, that makes it a little too complicated. And even if I did explain it, John, you wouldn't believe me anyway. So fortunately today, we are joined by Professor of Law Alison Hoffman from the University of Pennsylvania. And she, unlike us, John, she's actually an expert in healthcare law and policy, and she's going to enlighten us on 340B and so much more. And I should mention, John, that I had to go way back in the annals for this one because I've known Allison, but we actually haven't spoken in some time.
Well, you look a lot older than she does, so that's kind of...
Oh, John, don't make comparisons, first of all.
Welcome. Allison.
Yeah.
Thank you. It's fun to be here.
So can we start with the basics? 340B, what is it?
340B was a program that was created in 1992, and it was created at the same time as the Medicaid drug rebate program. And what it does is it says to drug companies that you have to offer drugs at a discount to certain qualifying what are called covered entities, hospitals and clinics. And to get technical for a moment, there's a group called the Health Resources and Services Administration, HRSA, that administers this program, and they set a ceiling price. And so they say you have to charge somewhere below this price when you're offering drugs to these 340B hospitals and clinics. And so that's the basic program. It's just a way to provide certain hospitals that are serving, in theory, underserved populations, discounted drugs.
But those hospitals are really in a lot of very high need areas, and they're financially pretty fragile. I think, Allison, this is the 340B program, even though there's HRSA and 340B, it's really a way to make sure that hospitals that are, or the purpose I think was that, correct me if I'm wrong, that if hospitals are serving in areas through compensated and uncompensated care where there's a lot of poor and high need populations, that they would not be overpaying for drugs like all of the rest of us.
So the statute didn't say what the purpose of the program is, which is part of the complexity here. HRSA has said exactly what you said, which is that these dollars, so they get the drugs at a discount, and then they still charge the Medicare and private insurers higher prices for those drugs. And then they keep the spread, they keep the amount in between. And so HRSA has said over time that that's the purpose of the program, is they get to keep that spread and it can subsidize other activities that they're doing to serve underserved populations. But the statute didn't actually say that, so that's one challenge. And then the statute also said that there are these qualifying patients, but it didn't say who those qualifying patients are. And so over time, HRSA has also interpreted that to say, essentially the patients you serve are your qualifying patients, and it doesn't matter if they're uninsured or if Medicaid is paying for their care, Medicare or private insurance. You can take these discounts, these drug discounts, and then bill normal charges for the drugs, and then you get to keep the difference between what the drug company sells you the drug for, what Medicare pays, or what the private insurer pays. One complexity, and I think part of why we ended up seeing this case, is that this program has just ballooned over the past decade. And so in theory, it was to help these covered entities, these clinics and hospitals serving underserved populations. But I think in 2014, an estimate was that 45% of Medicare's acute care hospitals were qualifying for the program. And so as you see the program grow, there's a little bit of pushback on whether it's actually doing this kind of tailored thing that you could imagine that it was intended to do, even though Congress didn't say so explicitly.
So, John, you gave this little sort of sob story about, oh, it's helping out the poor little hospitals. Now, from what I can tell, there's a well-known pediatric hospital in my neck of the woods, and they sent me a gigantic bill for one of my kids to have medication administered.
You could pay it.
I'm not this one, John. This had a lot of commas on it. And as far as I know, they're a 340B hospital. I have commercial insurance, and they're just sticking it to me, to the insurer. Even my copay was huge on it. And so I think that's what it's about, John. Just another ripoff till Allison tells us otherwise.
But David, if you the 340B program, Allison's making a really important point that it was imprecisely drawn. But the winner, if you removed it, would be your friends, big fat margin pharma that raise their prices monthly. And the loser would be a lot of hospitals in very high need areas, which the federal government would have to pay anyways. It's really a backdoor way to subsidize the very thin margins for high need hospitals. And I think that's why Allison, correct me if I'm wrong, that's why it's so prone to litigation, because of the imprecision and because honestly, there's a lot of dollars in this program.
Well, John, let's have her explain what this case was about, because as far as I could tell, it's billed as this big 340B case before the Supreme Court, and it turns out it's some kind of survey for 2 years. I mean, what the heck, Allison?
So the case, so first, let me say that the part of the imprecision in the statute is it doesn't say that savings have to be passed through, and so that's what you were experiencing. And then there's also a challenge where with Medicare, which I'll talk about because that's what this case is about, that when patients are using these drugs who are Medicare patients, they pay for a share of those drugs. And there's nothing in the statute that says that they pay 20% of that lower cost, of that discounted cost. And so it's the same way that you saw a high price tag for these drugs, Medicare patients were as well, which is the other piece. It was the fact that the number of hospitals that were getting these discounts had increased, and that Medicare patients were paying high cost sharing for these drugs that led to HRSA and CMS to be thinking about this program structurally. So here's what happened that led to this case: is that Health and Human Services, CMS, which sets the prices for drugs, decided that starting in 2018, it was going to pay the hospitals, these 340B hospitals, a lower reimbursement rate for certain drugs that are outpatient drugs administered in hospitals. So these are things like cancer drugs that you get an outpatient basis at hospitals because the hospitals were paying lower prices, and so CMS said we're going to pay you lower rates, which from a business perspective seems quite logical. But then from a legal perspective, if you look at the statute actually, the Medicare statute lays out how CMS has to reimburse for these drugs. And what it says is that if you can survey the hospitals to figure out how much they're paying for these drugs, you can pay them based on their acquisition costs. If you don't survey them, you have to pay them based on average prices. And average prices are defined as average sales price plus 6%. And so historically, CMS had been paying average sales price plus 6% to all the hospitals for this category of outpatient drugs. Then for the year 2018, they put a new rule in place that said, well, 340B hospitals, we're going to pay you less. We're going to pay you average sales price minus 22.5%. And the hospitals challenged it. They said, you can't do that based on the statute. And that's what this decision was about, really was, can the statute, under the terms of the statute, can they pay less to these 340B hospitals? And the court said no. The court looked at this language in the statute and they said, it's beyond the bounds, CMS, of what you're allowed to do when you're setting prices, because it tells you can only charge based on acquisition costs if you've done this survey, and you haven't done this survey.
So the whole thing seems like it came down to 2 years and like $1.6 billion, which is less than Elon Musk's makes on a good day. And if I understand it right, first of all, then they remedied the survey methodology, so it's not even relevant for later years. And this 1.6 billion, it's not as though there's some place to just like hand it out. They got to grab it back, claw it back from the other hospitals that got it. So it's like what's actually going to happen now?
So it's $1.6 billion a year for 2 years. So it's a little more, but still small in the scope of a program that is $800 billion a year. It's, it's kind of a drop in the bucket. And what happened for that $1.6 billion a year in 2018 and 2019 was instead of paying it out, so there's something called budget neutrality in Medicare where you have to, if you decrease spending in one space, you have to increase it in the other. So when they decreased the spending for these 340B hospitals, they took that money and they essentially paid it to all of the Medicare hospitals for outpatient services. And so now they have to try to fix this problem, and it's not clear what they'll do. And the courts kind of said, they washed their hands of it. They said, that's not our problem. Yeah. That's your problem to fix.
It's a little weird that these what seem like policy discussions need to be resolved and directed by the Supreme Court. I mean, it's just, there's a bunch of other things you'd expect the Supreme Court to be weighing in on. Is this kind of where we're going in terms of healthcare regulation, Allison? And do you think it makes any sense?
So the Supreme Court with this case essentially said the courts aren't going to fix your policy problems for you. And they sent it back to Congress. They said what this language says is that that CMS has to pay average prices unless they collect survey data. And if they collect survey data, they can pay based on what that data says hospitals are actually paying acquisition costs. And if you want to do differently, Congress, you actually have to say so. And so really, this is a case where the court kind of says we don't want to play with this. We're just going to look at the statute. It's fairly straightforward, and this is an issue for Congress. But John, you asked a question that is really relevant for a larger trend that is happening in the court right now, which is how much the court is willing to step in or not step in with decisions that agencies are making, that Health and Human Services and CMS are making. Which do have huge policy ramifications. And one of the things that we'll see, I think, in the next month, as the Supreme Court continues to issue opinions, is that they are likely to change the balance of what Congress can do and what agencies like Health and Human Services can do quite dramatically. So I think, this case ended up not having a lot of policy relevance, but I think we'll see some decisions in the coming weeks that are going to quite likely decrease the ability of HHS and CMS and other agencies to regulate going forward.
Well, and Allison, I think you're I'm sure you're much more aware than I am that there is a broad federal society support for this notion that a lot of the regulatory history from FDR through yesterday would actually enable the agencies, in their views, EPA, SEC, HHS, to do their job. But there's building over the last 30 years, the Federalist Society, the conservative legal society that's provided a lot of the litigation bar, lower level judges up through the Supreme Court that have been looking to strip this historical power that the agencies have had to,
John, you don't like that word deference. I know you want to say deference in there somewhere, John.
No, because I think I want to be careful with the words, because it's historically the last 60, 70 years, the agencies have been able to manage their responsibilities and make decisions. And I think that this is an interesting case, at least from my perspective, Allison. Love your comment on it, because I feel like it is this is one of a number of cases that are going to be put in front of the Supreme Court, which is fairly conservative, I've heard, that are around this notion of what should federal agencies be able to do and not do.
So that was the version of a decision that could have had much greater implications. Is that one of the issues that they talked about in this case is whether the court should, and I will use the word defer, whether the court should defer to Health and Human Services in their decision in this case. And so this case could have been monumental legally if the court had used it as an opportunity to say that courts have been deferring too much to agencies, that they've given agencies too much leeway, and we need to call back on that deference. In legal terms, it's often referred to as Chevron deference, from a case called Chevron, which was an environmental law case. And so this case, if that had been the decision, everybody would be talking about it right now. And that's not the tack that they took with it. But you're absolutely right that there are There are, I think, 5 justices on this court now that were moved through with the support of the Federalist Society. It's a court that is inclined to want to decrease the ability of agencies to, kind of their leeway to use rulemaking in order to keep the wheels of the government turning. And so I think we're likely to see a lot less space for all of the agencies to be able to act going forward. I know one of the big case that is likely to be the one that they use to make a statement in this space is a case called West Virginia versus EPA, which is about climate change and climate change regulation. And so that case, if they say, the agency has overstepped its kind of what Congress has told it can do, its statutory bounds, and we're not going to defer to it, and we've been deferring too much to agencies. That case, if they call back the space for agencies to act, won't just apply to the EPA. It will apply to all of the agencies that are operating in the healthcare space as well, from HHS to the FDA to the CDC, and give them kind of less opportunity to make rules and to make things happen going forward.
So, John, you have this way of going from this little esoteric thing, which is interesting and troubling in and of itself, and lead to stuff that's like the end of the world, which I agree could happen, but it's not for another month or two. I mean, let's enjoy ourselves until the Supreme Court comes down.
David, I actually think that Allison's more on top of this than you are, but that's not
no kidding.
A typical thing for me. But I do think that there is a strategy that is a 50-year strategy around, if you will, stuffing the courts in plural, with those who support an ideological person that deeply believe that unless specifically defined by Congress or state legislatures, that agencies should not be able to make decisions, interpret rules, and execute their responsibilities more broadly, other than that which is narrowly defined in the law. What that would mean in practice is a shrinking authority and sending more decisions. We're looking for decisions from our legislators who don't seem to be able to agree on anything.
Yeah,
so it is actually John, pretty profound. And even if you can't connect the dots here, David, I think Allison can.
No, John, okay. Yes, Allison is more on top of it than I am. But the point is, John, you should have been talking about this 15 years ago and not now,
I was.
Right now it's
we
too
didn't
late.
have a podcast.
Well, you should have been more effective. You should have been more effective. Now, Allison said she writes about Medicare too. And I know you like to talk about climate change and, the stock market and all these so-called important things. But I want to talk about some Medicare. So can we talk about the public option? And, not so long ago when we thought things might go in a different direction, there was discussion of Medicare for all. We heard about the public option. And Allison, you're, I think, a skeptic of the public option, and I don't know about for Medicare for all, but you had an interesting proposal, and I was wondering if you could describe it about an employer-sponsored insurance and how that relates to the public option.
Sure. So I've been working on a project with Howell Jackson, who's at Harvard, and Amy Monahan at Minnesota, to think about whether it would be more powerful and greater impact to offer a public option to employers rather than to individuals. So we came to this idea from what you were talking about, David, which is we were looking at these 2 ideas that kind of framed the Democratic primaries in the last election, one of which was this notion of a public option for individuals in the ACA marketplaces, and the other, which on the opposite extreme, was Medicare for all. And we looked at this individual public option and said, this thing is going to be controversial and not have a lot of impact. There are only a small percentage of the population buys this individual coverage. Even if you offer them a public option, most won't be able to figure out if it's better than what they have now. It's not going to have a big splash, and it would be a huge lift to make it happen. As we saw it, it's not going to happen. And then on the other hand, you have Medicare for all, which most people agree would be a more eloquent system than what we have now, but it's really hard to get from where we are now to there. And even just looking at kind of the budgetary estimates of what it would cost tend to take it off the table. And so what we thought about is there something that could move us to a more efficient and a more equitable system that doesn't take that full leap to Medicare for all? And so we kind of combine that with another problem that's out there right now, which is that employers are really struggling to offer health insurance to their employees. They have, for the past 70 years, have become the main source of, half of the population gets coverage through an employer. But employers are increasingly buckling under the prices of healthcare, which are rising rapidly, and are looking for help. And so the idea, with a lot of wind up, is why not give employers the opportunity to enroll their employees in Medicare, in a Medicare public option, and so it would give employers what they want, which is the ability to use Medicare to offer less expensive coverage to their employees, and so long as you tailored it for the working population, it could continue the kind of high quality health insurance coverage that employees have grown accustomed to. And so the notion is, if it worked and people liked it, that you get a few ideally large employers on board, and then over time, more and more people would say, well, that might actually be the easier way for me to get my employees' health insurance coverage, and it would grow kind of organically the footprint of the Medicare program, which provides good coverage and has the ability through regulation to set prices.
And so, Allison, how much would that one cost? If
Depends
Medicare
how
for
many.
All
It
would
depends.
be
So
crippling.
yeah. So as often is the case in early stage projects where we're thinking about the big ideas, we didn't build the models yet, but a lot of it would depend on things like how much do you pay for services. You'd probably have to pay a little bit more than Medicare pays now in order to deal with the fact that hospitals and other providers will lose some of their kind of high private pay business.
It just contextually, David. Maybe we just take a moment to say people may not realize that employers pay a 15 to 20% premium roughly to everything that Medicare pays, and Medicaid is paying probably 85 cents to 75 to 85 cents on the dollar relative to Medicare. So effectively, private insurance is subsidizing the lower prices for Medicare and Medicaid. And what's happening, particularly in an environment with high inflation, is that the premiums that the health insurers, who often aren't managing care that effectively, are transferring to large and small employers, is actually undermining their ability to provide benefits, and the benefits are shrinking. And you sort of also wonder, Allison, that even if you unpack this, whether you could actually leverage either MA plans or Medicare to start to bring down costs, because ultimately costs are the biggest challenge in our healthcare economy, and leverage the purchasing power of government. I know that cuts across ideological lines, but I agree with you. I don't think employers are going to be able to afford the premiums they're not going to need to charge to continue to subsidize a system that we've got today.
I think that's right. And if you look at what makes the U.S. extraordinary, and not necessarily in a good way when it comes to healthcare, we spend twice as much per capita as other similar countries do. And why we do that is because we pay more for every unit of care that we use. And all of those peer countries have some kind of global budget or regulatory way to manage prices, which Medicare has, but our larger system doesn't. So, those private pay prices are higher because they're not regulated, and because hospitals are powerful. When they demand prices, the employers through their plans have to pay them. And so this is one of those problems that going forward is going to have some kind of solution. But it's not clear what that solution will be. And our proposal is one to kind of get at it in an indirect way. One of the things that's interesting is, even though we talk about these private pay, these private insurance plans as subsidizing other coverage, if you look at efficient hospitals, it used to be until very recently that they could break even based on Medicare rates. Now they are slightly below that break even point, but it's not a huge gap. People talk about the fact that, Medicare doesn't pay enough to make hospitals run, but if hospitals operate efficiently, Medicare rates are pretty close to that point.
So, David, what's your quick reaction?
Well,
you're looking very smug there.
John, I'm looking smug. As a private employer, paying for health insurance, and not only paying a lot, but then also as a taxpayer, you've got to pay additionally for Medicare and Medicaid. So you pay for all different ways. But John, the reason I was looking smug is that because I have my final topic is one that you're going to like, okay, which is a big one. Okay, so I know we don't just want to talk about 340B or healthcare, but how about civil rights? Is that a big enough topic for you? So there've been some people who said, there's not much progress going on in civil rights in the country today. So maybe another way to look at it is like, what's the impact on people's health of being in a certain status, and can we actually address it that way? And some big names from Stanford wrote a whole paper about it, and Allison actually wrote a letter saying it was bullshit, to paraphrase, and that she just she said it as it was more, they would be disappointed that it was a more limited approach than they might think. But Allison, please explain yourself, because I know you didn't say what I actually just said there.
Okay, yeah, I definitely didn't say that. I was writing in response to a piece that I think is a wonderful piece by Craig Conniff, who's a law professor who's at University of Virginia now. The piece was published in the Stanford Law Review. His piece was, and it was about the medicalization of civil rights. And to oversimplify it, he showed how all these efforts at civil rights, at LGBTQ rights and civil rights based on gender and race have really hit a brick wall. We're just not getting anywhere with these things. So what about if you thought about these issues through a medical lens, and you thought about how being a certain status could have a disproportionate and negative effect on people's health? Would that be a better hook in order to be able to kind of move the needle on a lot of the disparities we see on the ground? And I think it's a really clever and interesting idea. But I also think there is a problem when you come at these large social issues and social problems that we have indirectly, where you kind of try to you try to use a backdoor to get to a solution, rather than saying, well, we have a lot of racism and racial disparities in our country, and we really need to deal with them. You say, well, racial disparities, as we saw, for example, during the pandemic, right, have disproportionate effects on people's health. And so we should think about these as health issues and address them as such. And so that was really my pushback, is I think that that we shouldn't give up on the civil rights fight. And also that when you think about things through medical terms and through people's bodies, it could be reductive as well. It could kind of lose the larger purpose of why we have civil rights laws, why we have Title VII, and why we have these other protections in the law to begin with. And so it was fun. It was actually a really interesting thing where Craig wrote this piece, and then the Stanford Law Review asked me. They asked a couple of disability law experts and others to respond to it, and then Craig responded again back at us, kind of creating a dialogue.
Yeah, David, I don't think we're gonna we can't pussyfoot around the prejudice that is embedded in our healthcare. We've hit that on a number of other podcasts. We've got to deal with prejudice as prejudice. I think that's a really important point, Allison. So, David, what else you got?
I think that's it. I mean,
study our textbooks in order to come back with smarter questions for Professor Hoffman.
Well, here's the thing, John. I think that the Supreme Court may continue to rule in such a way that we are going to need Allison to come back and explain what goes further. And so what I'm going to suggest, John, is that we wrap up this episode of CareTalk and thank Professor Alison Hoffman for enlightening us on 340B and so many other things that we didn't tell you about, and say that's it for this edition. I'm David Williams, President of Health Business Group.
And I'm John Driscoll, the CEO of CareCentrix. Thanks for listening. And if you like what you heard, please subscribe on your favorite service. Thanks so much for joining us, Allison.
Thanks for having me.